Hello everyone. These new guidelines about the ovarian stimulation for IVF ICSI, they have been updated in 2025. So previously 2019 guidelines were there, so they have updated it. So I have included those guidelines in today's discussion. Because the guidelines are very long, so we will be discussing these in 4 parts. So today we will be covering the first part of the guideline. This is how the guideline looks like. First part is high ovarian response. Firstly, we must know what is high ovarian response. High ovarian response is an exaggerated response to conventional ovarian stimulation. What is conventional ovarian stimulation? When we are stimulating the patient with gonadotropins between dose 150 to 225 international units. So anything between that is known as conventional ovarian stimulation. So the high ovarian response is characterized by more than 18 follicles, more than 11 mm in size on the day of oocyte maturation trigger, or 18 oocytes collected characterize a high response. And what is low ovarian response? Low ovarian response is diminished response to conventional ovarian stimulation characterized by presence of low number of follicles or oocytes, generally less than 3 follicles on the day of oocyte maturation trigger, or less than or equal to 3 oocytes obtained characterize a low response. So these definitions must be very clear: what is high ovarian response and what is low ovarian response. Coming on to part A, the pre-stimulation evaluation, which will include the ovarian response prediction and the pregnancy prediction. So first is the ovarian response prediction. For predicting high and low response to ovarian stimulation, the guidelines say to use either intral follicle count or anti-Mullerian hormone. Age, BMI, basal FSH, inhibin B, the estradiol, basal progesterone, LH, they all are not recommended. So friends, last time we discussed the WHO guidelines on infertility. There they told AFC, AMH and FSH. These three things are there which can predict the ovarian reserves. So here we have to know the difference between ovarian response prediction and ovarian reserve prediction. So these both are different things. Ovarian response prediction means when we stimulate the ovary, how the ovary will respond. That for predicting that, AFC and AMH are important. But what the reserves of the ovary are, that basal FSH can also tell. So there is definitely a difference which we must understand between ovarian response and ovarian reserve. Pregnancy prediction. So all these things which we just spoke, they are not recommended for prediction of pregnancy and live birth. So none of the tests they can predict the pregnancy, because these all tests are the quantitative assessment of reserves and the response. They cannot tell about the quality. So female age, the basal metabolic index, these are the only two predictors of pregnancy. So this is very important. The ovarian reserves as well as ovarian response markers, they cannot tell about the pregnancy. Female age and BMI are the predictors of pregnancy and live birth. Coming on to part B of the guideline, the pre-treatment therapies. What is meant by pre-treatment? Pre-treatment means the hormonal medications or non-hormonal medications which we give before the start of stimulation. There are some reasons why we give these medications. The first and foremost reason for giving the pre-treatment therapies are the scheduling purposes. They help to, like if we want to do the batch IVF, so to schedule the patient, all the patient to the same, to synchronize their menstrual cycle, the pre-treatment therapies help. The other reason which used to be there was they were supposed to improve the response to stimulation, which the newer guidelines have not felt that they improve the response to stimulation. So that's why for that purpose the pre-treatment therapies are not given. The sole purpose of giving the pre-treatment therapies is the scheduling purposes. So what pre-treatment therapies we can give? One is the estrogen, second is progesterone, then combined oral contraceptive pill, the gonadotropin releasing hormone antagonist pre-treatment, and the HCG pre-treatment. So these are the various pre-treatments which have come into the market and which have been tried. Let's discuss one by one these. The estrogen pre-treatment. Pre-treatment with estrogen before ovarian stimulation using GnRH antagonist protocol is not recommended to improve efficacy. Just what I told, just for improving the efficacy, these pre-treatments are not indicated. The only and only reason for giving them are scheduling purposes. Second is the progesterone. Again, it is not recommended. Only use is the scheduling purposes, given the data on efficacy and safety, because they do not improve the efficacy. The combined oral contraceptive pill pre-treatment, that is also not recommended in gonadotropin releasing hormone antagonist protocol because it is associated with reduced efficacy. If we are using the COCP pre-treatment, a minimum washout period of 5 days should be given before starting the cycle stimulation. What is meant by minimum washout period of 5 days? It means that before starting the next cycle, the stimulation of the next cycle, it should be the last dose of the COCP should have been given more than 5 days back. So that is what is meant by washout period. The gonadotropin releasing hormone antagonist pre-treatment, which is also known as sandwich protocol, so that is also not recommended. HCG pre-treatment. HCG pre-treatment can only be used in context of clinical trial. So in a crux, all the pre-treatments are not recommended to improve efficacy but for scheduling purposes. Coming on to part C of the guideline, which is the ovarian stimulation and the pituitary suppression. So there are different ovarian stimulation protocols as well as different pituitary suppression regimes which we will be discussing. What guideline has to say for regarding these things? The first one is the ovarian stimulation protocols. We will discuss high responder, normal responder and low responders separately. The high responder, delayed start ovarian stimulation is not recommended to decrease the risk of OHSS. What is meant by delayed start ovarian stimulation? Usually we start the ovarian stimulation either on second or third day. If we are starting the stimulation in the follicular phase later than second or third day, it is known as delayed start. But that is not recommended because it does not decrease the risk of OHSS. Reduce gonadotropin dose. In the previous slides, I told what is conventional ovarian stimulation between 150 to 225 international units. A reduced gonadotropin dose means anywhere between 100 to 150 international unit is probably recommended to decrease the risk of OHSS in predicted high responders. A gonadotropin releasing hormone antagonist protocol is recommended for predicted high responders. Coming on to ovarian stimulation protocols for normal responders. Again, the delayed start ovarian stimulation protocol is not recommended. A conventional gonadotropin dose equivalent to 150 to 225 international unit for predicted normal responders is what is recommended. Ovarian stimulation protocols for low responders. The delayed start ovarian stimulation is not recommended for low responders. Use of modified natural cycle is also not recommended for low responders, but in the patients who have very low ovarian reserves, the clinicians could choose to use a modified natural cycle. A gonadotropin dose higher than 300 international unit is not recommended. the guideline prior to 2019, the dose was 450 international unit, but in 2019 they changed the dose to 300 and they are maintaining with that. So that is what is recommended. Anything more than 300 is not recommended. Coming on to pituitary suppression regimes. Guys, why we want to use the pituitary suppression regimes? Because if the pituitary has not been suppressed, there will be LH surge, and whatever stimulation we are doing, that will become useless because the insufficient ovulation can happen, and because of the self ovulation, the follicle wastage will happen. So that's why we have to suppress the ovary to get the desired number of the follicles by the day of trigger. So we will be discussing the pituitary suppression different regimes, so which is recommended and which is not recommended. First is the gonadotropin releasing hormone agonist protocols. The only agonist protocol is the long agonist protocol, which is recommended. We have already discussed all these protocols in our previous videos. The all short, ultra short, these all protocols, they are not recommended. The only one which is recommended is the long GnRH agonist protocol. If you have any doubts what these protocols are, you can go back to the other videos and check that. In the GnRH antagonist protocol, the GnRH antagonist protocol is recommended over agonist protocol given the comparable efficacy and higher safety. Although the efficacy is same, but efficacy is same, but the safety profile of antagonist protocol is much more higher in general IVF ICSI population. There is a change in 2025 guideline over 2019, that the 2019 guideline used to say the fixed as well as the flexible protocols are equally recommended. But the 2025 guideline says the fixed GnRH antagonist protocol is probably recommended over the flexible GnRH antagonist protocol. In our previous videos, we have already discussed what is fixed and flexible protocol. In a crux, the fixed protocol is we are starting with GnRH antagonist on day 6 of the stimulation cycle, while with the flexible protocol, we are starting the gonadotropin antagonist once the follicle size, leading follicle size reaches 14 mm. This is also a new change. The progesterone protocol, if freeze-all is planned, the use of progestin for pituitary suppression is equally recommended to gonadotropin releasing analogs. Now, what is the advantage of using the progesterone protocols? Because the progesterone, just simply giving the progesterones, the cost cutting will happen, and the injection, sometimes injection site allergies can happen, and the cost of injection and the pain which patient suffers, all these things can be minimized if we cut down one injection, that is the antagonist or daily agonist. So that is what the use of the progestin protocols are, and the new guideline, it has updated it that it is equally recommended over the other gonadotropin releasing hormone, whether it is agonist or antagonist. So thank you guys. In our next video, we will be coming up with the second part of the guideline. So thank you.